Thank you very much, Saman, and all the colleagues uh, and all the attendees for inviting me for the lecture. So my presentation is on common eye problems and the challenges. So my aims of the lecture is to identify common eye problems and presentations, identify ocular emergencies, and to discuss the management briefly, identify patients for general ophthalmological referral and the challenges that uh, has been faced. So overview, to understand the lecture you have to revise a little bit of anatomy and physiology, and I'll be talking on certain topics: tearing of a newborn, trauma, squints, corneal ulcers, red eye and conjunctivitis, refractive errors and keratoconus, glaucoma, bit of retinal detachment, diabetic retinopathy, hypertensive retinopathy, central retinal vein occlusions, chemical injury, and some investigation that we perform in the eye units, then the challenges, and then open for the questions at the end. So as you know, the eye is the window to the world that we see, and to understand the world and to see, eye is the important part of the anatomy. So it contains the lacrimal gland, which produces the tears, which comes down to the lacrimal lake of lacrimal layers, and the tear is filled over here, and then it's drained on the medial side of the eye through the small punctum. Those are the openings, small ducts, and then goes to lacrimal sac into the nose. So that's the outer appearance, and it's covered by the bony orbit, and it's protected by the eye lids. And on so looking from the side, so these are the lids which protects the eye. Then this part is the cornea, the front of the eye, and this is the iris, and there's a small aperture which, like the camera, lets the light go through, and the lens is the one which, apart from the cornea, which makes sure the image is captured in the retina, like the camera. So see the same things again, a bit of detail. And here this fluid, anterior chamber fluid, it's been made from the ciliary body area here, comes through to the front through this area in front of the lens, and it's been drained to the angle, what we call the angle in the ophthalmologist. So it's the angle between the front of the iris and the back surface of the cornea. And there is a vitreous gel, and that is in between the lens and the retina. So the multiple layers, the retina is the part where the image is formed, and surrounding it is the choroid, which gives the blood supply, and then sclera is the outer protective layer. Then you have the extraocular muscles which move the whole of the eyeball, and these are included in the orbit, which is the bony structure protecting the eyeball. So we'll be talking about a little bit of glaucoma. As I said, ciliary body produces the fluid, comes through the pupil and drains into the angle, and there's a small canal which drains the. So when there's an imbalance between input and output, then you will have high intraocular pressure. Going into the teary eye, so especially in a child. So most of you doctors might come across the teary eye in a young child. So you just visited the anatomy. So generally in a child, it's a problem with the lacrimal outflow or the tear outflow system, and there are certain If you go back, in the nasal lacrimal duct, there is congenital flaps which are there, like there's a valve of Hasner, valve of Muller. So those are there, which prevents the normal flow of the tears. What happens is, like when the child grows, these regress a little bit, and then it allows the tear to go to the nose. And what we need to do, if it is the pathology, there's basic massaging. With the pressure, these valves open up. So it's called the cricketer massaging. So how we do it is press on the lacrimal sac and then press it down. So pressure would drain the fluid down. So you can do it a few times every day, and like by 1 year of age, these open up, and the child would be symptom free most of the time. But you have to be a little careful, because there might be other cases. Just don't treat it, because it can be neonatal conjunctivitis, as most pediatricians know. Like it might be associated with infections like gonorrhea or herpetic infection. So sometimes they might have other systemic involvement like meningitis and lung involvement. So it's important to diagnose and to refer to the necessary personnel. So congenital glaucoma is the other thing. So it's one of the three cardinal symptoms of a congenital glaucoma is tearing. So it's better to refer the patient to an ophthalmologist or pediatric ophthalmologist to rule out the other causes, or it might be just a foreign body lodged in the lid. So if it feels fishy, make sure that you refer the patient, because it's children, the problems that the doctors face now with the litigation and other issues. So generally, congenital nasal lacrimal duct block, massage it down. You can add an eye ointment if necessary. Reassure if it is the cause, then review regularly. If not resolved by the age of 1 year, you have to do the probing, and then sometimes you have to do surgery as well. And sometimes it might be associated with an acquired block, and it can give rise to infection. And so the treatment might be surgical. And when it comes to trauma, especially in a child, sometimes it's difficult to identify a cause, and the child is not very cooperative. Examination is difficult, and they play around with various things. Rocks, branches can damage the eye, and it might be a blunt or a perforating injury. So you have to be a little careful in handling children, and you have to do a thorough job. And it might be associated with the subconjunctival hemorrhage, that is subconjunctival area surrounding the cornea. So it might be just a subconjunctival hemorrhage, and you have to always think of other associated injuries as well as non-accidental injuries. So it might associate with corneal lacerations, traumatic uveitis, that is the iris and uveal tissue inflammation, iris sphincter damage. So this is, the pupil is round, so it might be not be round any longer, and the lens which is behind the iris, that can get subluxated or move aside. And it's important to dilate the pupil and see the fundus, because they might be associated retinal tears, vitreous hemorrhage, traumatic retinal pathology, and of course blunt trauma without any other injury might be a kind of might look trivial, but might have a traumatic optic neuropathy. What happens in traumatic optic neuropathy, the optic nerve comes through the optic canal, and that trauma will cut off the blood supply, and the optic nerve will be permanently damaged. So all these things have to be seen, thought of, and recorded, because these can be medical legal cases as well. So there's how the round pupil with trauma doesn't look round anymore. So sphincter damage. So hyphema is blood in the antechamber. So you can see the blood here and the lens. So generally lens is just within the visual axis, so you won't see the edge of the lens here. So it's a sublux or a dislocated lens. And retina, you can see the whitish part. It's called commercial retina. It's due to blunt trauma. That you have to exclude all this, and you can have a traumatic macular hole, you can have retinal tears as well. Refusing to open the eye, severe lid laceration, severe bleeding. So it might be associated globe injury, might be associated bone injury. So globe rupture is when the globe is damaged, and you should not make the injury worse. So do not push the pressure on the globe, or do not try to pry open the lids, and clean the lids gently, and try to have an idea of the injury. If patient allows, you can gently open the eye and see what is inside, and if you have a preservative free antibiotic, you can instill the drops. But if there is a continuous injury into the eye, then these antibiotics with preservative can go inside and damage the integrity. And best thing is to keep the patient fasting, and if you can take an ECG. And sometimes the most difficult thing in the night is getting an ECG done, and it's a problem for the anesthesia. And then keep the patient fasting and send to an appropriate ophthalmology unit. And sometimes persistent pain and irritation can be associated with corneal epithelial defects and corneal and conjunctival foreign body. So this one you might not be able to see. There's a small foreign body here. So even for the trained eyes, sometimes you can miss. So it's always important to invert the lid and see the underneath of foreign bodies. And sometimes it's very visible, like here. It's corneal foreign body over here. So sometimes you can detect it with just a torch, but it's better if you send the patient to be seen with the slit lamp. That's the instrument that we see with the magnification. So sometimes epithelial defect, here there's an epithelial defect, it's not very visible. So that's why you need to stain these injuries to make sure that you don't miss. And how to invert the lid. So you pull the lid with the lashes down, ask the patient to look down, and you can use a cotton bud to press it down. So so important thing is the patient to look down. So that gives space in the upper fornix, this area, so you can invert the lid. Sometimes, like in trained people, it's easy, like that's a good practice to check, because sometimes even with the chemical injury, sometimes you might have large particles underneath the eye. So sometimes you can easily remove it before sending. So delayed presentation or delayed treatment, if there's a corneal injury and corneal infection, can give rise to a corneal ulcer. Especially if you inadvertently use steroids, you can give rise to a corneal ulcer which progresses, and then the patient might end up with blindness. So this is how the eye progresses into a corneal infection, and sometimes the whole eye, we call it endophthalmitis, and then you probably might have to do corneal graft, and you might have good outcome, or you might not have good outcome. So important message is to avoid steroid or steroid combinations unless you have stained and examined the eye under slit lamp. So red eye is also a very common presentation. So commonest is conjunctivitis. So this diffuse conjunctival redness, and the cornea is clear, and the immediate areas around the cornea is kind of whitish rather than red. So it's more on the peripheries which is red. corneal ulcers, I will discuss a little bit. Uveitis is a ciliary injection that is surrounding the cornea. It's more red rather than the periphery. Scleritis or episcleritis, we just visited the anatomy. So it's the outer part of the eyeball where there is a nodular or diffuse inflammation. It might be in the whole area, the front or the back, or some sector, the whole thing might get. So it's kind of a scleritis, which you see this is diffuse anterior scleritis. The whole area is red. So it doesn't. So it's not just the fornix. It's not the surrounding the cornea. The whole thing is. And sometimes these things are seen better with the not in the slit lamp. Sometimes you can miss it in slit lamp. You always have to have the habit of testing it in the with a torch or something, because they have this violaceous hue or kind of pinkish violet appearance in the scleritis, and they are presented with pain. So trauma, subconjunctival hemorrhage, we just discussed on it. Another cause of blepharitis is lid inflammation. So people might have lid issues. Any cause of irritation like entropions, lid turning in, turning out, lashes touching the eye, dry eye, or cause red eye. So conjunctivitis, the commonest cause of red eye. Viral, commonest, bacteria is rare. And sometimes the infective cause of conjunctivitis might be associated with fever, pharyngitis, and sometimes preauricular lymph nodes. Generally, it's not painful, but then it's associated with gritty feeling, a bit of mild discomfort. But the eye is generally severe and there's gum or discharge in the morning. And allergic is non-infective form of conjunctivitis, commonly in young adults where the immunity is, at its peak. Young children and young adults, itching is more common, and it lasts for weeks to months, and discharge is milder. And commonly conjunctivitis is infective, mostly adenovirus. It's highly infectious. Antibiotics are only used as a secondary infection, but as you know, most antibiotics have a not so much discussed anti-inflammatory effects. So that's why probably most for viral infections that it works as well. So important is to prevent cross infection, because if you touch the eye to put the drops or otherwise, make sure that you wash your hands thoroughly. So suggested treatment algorithm is, you can use an antibiotic such as an ciprofloxacin and chloramphenicol, but then you should make sure that you're on the right track. So if it is not improving within few days, or if the vision is impaired of this pain, of course it's better to refer to an ophthalmologist. So squint or suspected squint is another condition that we get. So sometimes it might be a normal appearance, it might be evident all the time, or sometimes it's not evident all the time. Occasionally it appears when the child is kind of not concentrating. So you have to carefully examine the squint, because there are eyes turning in, out, up, down. So it might be associated with fractures or other pathology where the nerves are and the muscles are involved, or it just can be a squint of normal origin. So it's important to examine the eye, do a fundus examination, check for refraction to check whether the child needs glasses, and to orthoptic assessment is the squint assessment specifically. So it's important while examining fundus. Sometimes in a child presenting with squint, sometimes they can present with retinoblastomas, which is a malignancy in the child. which can, if not treated, can result in the child losing the life as well. So it's important to do the routine examination in a squint. So sometimes you don't need surgery. Sometimes spectacles is enough, like this, like refractively corrected squints. Then you have to correct the amblyopia, because sometimes one eye might be slightly lazy than the other eye. So you have to correct with the glasses, and you have to close the good eye and make sure the eye which is not performing, that it sees with the other eye. And you can give Botox injections to weaken certain muscles to make the eye straight, and you can do squint surgery. So going on to refractive. So refractive, as you know, most of you wear glasses at some point of your life. So there are few types of refractive errors. Myopia is like you see the near well, but you can't see the distance. Myopia, where they use the negative lenses. Hypermetropia, people who use positive plus lenses. Astigmatism is like, I'll come to that, and presbyopia. So basically, all refractive treatment, the treatment is glasses, contact lens, or surgery. So normal vision, the rays coming from infinity, the refraction 2/3 is by cornea, 1/3 is by the lens. So at one focal point, they converge and you see the image clearly. So astigmatism is, generally they converge well, but at a certain degree of angle, either it falls in front or falls behind. So for that specific angle, you have to have a lens power put in. So generally this is emmetropia, that's normal person who has clear vision, the rays coming from the distance. Myopia is they can't see the distance, all the images are in front of the retina. So you have to have a divergent lens for the image to fall back onto the retina. Hypermetropia, you have to have a convergent lens, so the rays fall back on the retina. So these are the pictures of astigmatism, one area, and then correction. So these are the prescription. So the cylinders are for the astigmatism. So at this axis, you add a lens. So a certain axis, 140 axis, 100, like this. So you will have a perfect vision. And so these are the prescription. And children, you have to, at least once you have to assess the fundus. And in children, their eyes are very strong, so at least sometimes, like, you need to nullify their able to contract the lens. So you have to put the drops and nullify and wait for like half an hour and get the refraction. And the children need refraction every like 6 months due to their fast growth, because it keeps changing. And because nowadays it's much more common, because children are more into the computers and tabs, and they are not used to the distant work, playing outside as much as they should do. And if the vision is reduced during an eye checkup in a school or in the assessment, then better to refer to an ophthalmologist. So contact lenses and laser refractive surgeries are the other ways of correcting the refraction. Presbyopia, we all go through this. So it's about, when you're growing old, our lens, normal crystalline lens, it doesn't have the ability to focus from the distance to the near. So it doesn't happen suddenly at the age of 40, but our ability to do the near things reduce slowly. Like for a child or young person who's like 15 years old, they can see things this clear, this close. But then that ability by 20 years, probably this 25, 30, 35, 40 comes to our working distance. So it's about our working distance that matters. Like if we are used to see things like 1 meter away, then probably we don't need glasses for presbyopia. So the glasses what we need is like you have a distance area and the near area. So these are bifocal lens where this area is for the distance. Probably we don't need glasses or small correction, and this is for the near area. And then there are trifocal areas, near and intermediate for computers as well, and progressive lenses. So distance, near. So there is a progressive corridor, you call it, and so you see everything, and you don't have this demarcation lines in the glasses. So these are much popular now. And when the progressive corridor is wider, the lens is much expensive. And the slight issue with this progressive lenses is the way the lenses are cut. These areas, the sides, they get congested, and you can't avoid that. And sometimes you can't see the sides clearly. So if you are driving, sometimes early on, you have to change your head neck position early on, but it would be after like a few weeks you'll get used to it, and that's a normal thing. And also it's important, like sometimes you can't judge the distance in the first few weeks. You have to be very careful going down the stairs. So keratoconus is another refractive condition where the cornea becomes thinner progressively, and it's about a problem with the collagen molecules because it makes a weaker cornea and gives rise to refractive errors. And usually it starts in the teen years, early 20s, and the maximum corneal strength is by the age of 35. So eye rubbing worsens this condition, and if it is starting in the young age, the progression is faster. So you have to catch them early. And if somebody is changing the glasses frequently, like every 3-4 months or every 6 months, then you have to think of it, and you have to do a corneal topography to find it out. So you see the normal cornea, how it thins out. And since the cornea is the main area of refraction, 2/3 of the refraction is by cornea, so this gives a marked poor quality of vision. Then going on to glaucoma, there are two types, open and close angle glaucoma. It's kind of a progressive optic neuropathy, which corresponding visual field defects. So this normal person can see this. Early glaucoma, the peripheral vision slightly goes down. Ultimately, they end up in tunnel vision, and this also goes to an irreversible blind state. So risk factors, multifactorial, family history, age, diabetes, sometimes optic nerve perfusion also plays a role. So sometimes it's people with sleep apnea or other causes where the optic nerve doesn't get perfused properly, especially in the night, sometimes they will progress. So treatment, there are aqueous suppressants. As you know, the aqueous is produced here. So if you suppress the aqueous production or increase the drainage, so those are the ways of treatment. So early on it was medicine and surgery. Now for open angle glaucoma, according to Royal College of Ophthalmology guidelines, SLT or selective laser trabeculoplasty is the first line now. And the machines were not available in Sri Lanka, but there's one machine in Colombo. So sometimes if I feel the cost of, it's not easy to put it up, sometimes I ask the patient to come to Colombo and I do the SLT, even though it's not my specialty, but it's a procedure that you can offer, because the recent trials suggest this gives as good or better outcomes than the drops. So surgery is trabeculectomy or glaucoma drainage device, where you increase the drainage by creating an alternative path. This is the open angle glaucoma. But then this acute angle closure. So here acute angle closure, sudden rising in the eye pressure because the drainage angle is blocked. So might be various causes, can be trauma or can be subluxated lens or any other issues. So sometimes these patients come up to the general med wards because they come up with headaches, other sometimes ear aches, various kind of symptoms. So they do not comprehend that it's eye problems. Come with the pain, sometimes severe pain. Whereas open angle glaucoma, very rarely you'll come across with pain, and generally it's by screening or some kind of when they come for regular eye checkup, they'll get caught with the glaucoma open angle. Here it is much more symptomatic, especially the pain comes in the evenings when the pupil dilates a little bit and makes this angle much more congested. So yeah, with vomiting, pain, you have to give the symptomatic relief and reduce the aqueous production, and the treatment is you can give laser iridectomy to create an alternative pathway to make the entry chamber deeper. And the definitive treatment can be cataract extraction, because when you take the cataract out, the iris comes back and opens the angle. And if there's a secondary cause, then you have to treat a secondary cause. And then people will come for us with flashes and floaters. So generally it's kind of a degenerative process where the vitreous gel, which is behind the lens, which is between the lens and the retina, becomes like aqueous with time, and the gel, which is firmly attached to certain places, can start pulling up. So then the retina, when the retina is pulled at certain area, the retina interprets as a flash. So it's kind of a sensation where the brain interprets it as a kind of a flashing sensation. So what happens is that generally the vitreous attachment can come off the retina spontaneously, but sometimes it might just pull it, and sometimes it might cause retinal tears. In that phase, if you identify, you can give lasers and make sure it's pasted to the surrounding retina. And sometimes this retina, the tears, the fluid might go back and the whole retina can come off. It's called a retinal detachment. So this is a detached retina, and there is it's not very clear, it's a retinal tear where fluid goes through and the retina is. So here it's a retinal tear, and you have given a laser around that, so the retina remains flat, so it doesn't progress. So if it goes and if the macula is also detached, so this is the vascular arcade, then your vision also goes down, and sometimes it's difficult to correct. Then diabetic retinopathy, who gets it? The diabetes with longer duration, poor control, associated risk factors are more prone to get it. When should we screen? At the diagnosis, and if there's no retinopathy annually for the people with best prognosis. So I'll just rush through because it's kind of a separate topic itself. Why it happens? Diabetic macular edema. The macula is the area where you can see the best, that's in between the vascular arcades. It's commonly edema due to capillary leakage, can be capillary occlusion, and sequelae of ischemia, inflammation, and you have vascular endothelial growth factors and other factors secreted by the ischemic retina. So it can give rise to new vessel formation. Sorry. So you can see loss of small blood vessels which are not normal. These fronts of vessels which are due to new vessel formation due to ischemic factors, and you can classify it into non-proliferative, proliferative, and macular. So macular edema, when the macula is involved without much involved in the periphery, but still it's more symptomatic. Might be center involved or center not involved. Non-proliferative retinopathy, so there are mild, moderate, and severe. And proliferative, early, high risk, and advanced proliferative retinopathy. So when you go towards this side, that means difficult to treat, and so you should try to avoid coming into this stage. So it's mandatory for, I think, for the the doctors who see the diabetics to make sure they don't come into this stage, so they are referred early so they can treat it at this stage. And if you go to this advanced retinopathy and proliferative, it's very difficult to treat and the eyesight might be permanently lost. So this is the diabetic macular edema. This macula is the center of the retina where the vision is best. So you can see this the macula is swollen. So these are the diabetic changes. You can see the venous enlargement, multiple hemorrhages, and new vessel formation. So various stages is intraretinal and vitreous hemorrhages, and later on this the bleeding phase goes into the traction phase where the whole retina is pulled, and it's very difficult to treat at this stage. See the macula, this macula area, multiple hemorrhages and multiple exudates. Sometimes very difficult to get rid of these. So multiple cotton wool spots that indicates retinal ischemia. So how you review patients? Annual review if mild or no retinopathy, moderate 6 months, severe less than 4 months. And how you treat severe, you can either give lasers or can give injections. Proliferative, you might have to do surgery, retinal surgery. And macula, for center not involved, you can give focal laser treatment, and center involved, the treatment is injection. So sometimes proliferative you can give anti-VEGF, that's protocol is. That is not a very practical way because it's very costly. And if hemoglobin, try to maintain the glycosylated hemoglobin less than 7, but it's not mandatorily. Have a stable glycemic level, blood pressure systolic 140, anemia, hemoglobin more than 8, LDL for Asian population better to keep it under 100, and triglyceride control. Hypertensive retinopathy, sometimes we get referrals, especially if it is grade 4, right? It's like severe grade 3, that's flame shaped hemorrhages, cotton wool spots with papilledema, and grade 1 to general constriction, narrowing of vessels, AV nipping, etc. So screening, you don't need to screen hypertensive retinopathy because there is no ocular management is purely the management of hypertension. So generally you don't need to screen hypertension because it generally does not have a kind of an effect where the diabetes have. Central retinal vein and branch vein occlusions. So there are two types, non-ischemic and ischemic, and there are different changes that we see to diagnose whether ischemic or non-ischemic. So see the veins are tortuous and dilated, and sometimes retinal hemorrhages, and in the fluorescein angiogram you see multiple ischemic areas, capillary non-perfusions. So causes, commonly it's hypertension, and apart from that, age, diabetes, dyslipidemia, glaucoma, smoking can cause. Sometimes in young central retinal occlusion we do medical referral. Why? Because there can be other medical reasons which causes the central retinal occlusion. As you know, the vein occlusions are caused by the virtuous stride. Virtuous stride. So the effect pressure in a vessel, pressure from outside the vessel wall itself, or the contents within the blood vessel. So generally these things are generally the things which happens with the flow of the blood vessels. So these have to be excluded: antiphospholipid syndrome, myeloma, other malignancies, blood related, and inflammation associated with blood vessel walls, vaginous, granulosacoidosis, orbital, and renal failure. So macular edema, you have to give monthly injections to reduce the macular edema. Then you can do a fluorescein angiograms, and if you see the capillary non-proliferate area, you can give lasers. And if there's new vessels arising, you can give lasers as well. Macular degeneration with old age, there's accumulation of substances between the retina and the choroid. So that is one cause of blindness throughout the world, and associated with smoking. And so there's two types, dry and wet. Wet, we can give injections, and dry, we have to see whether it's kind of geographic atrophy and size of this drusen, with what you call drusen. Those are accumulations of substances, and if they are about certain, we can give some antivitamins. So going into chemical injury, can be accident, assault, occupational. So alkaline is more severely affecting the eye than the acids. So make sure you do the first aids properly. In the eye unit, it's a long and tedious process with guarded prognosis, challenging for the doctor and the patient as well. And what we see is, like, we see the lingual ischemia, try to re-establish perfusion and chronic management, including various procedures, including the lid and adnexial management, visual rehabilitation. But most important is the primary care. So that's for the doctors. Make sure you irrigate eye thoroughly for 20 minutes or longer, or if you have the litmus papers till the pH is negative. Make sure you wash underneath the eyelids, because sometimes these particles can be lodged inside. Direct jet of saline, wash it clearly, put anesthetic drop if necessary, because it might comfortable the patient, and transfer as soon as possible. And you have to give steroids for a long period. So ocular coherent topography, a scan where we see these are the investigations we perform in eye units. You can see each and every layer of the retina and a bit of choroid as well. So all the layers of retina, we see the pathology where it is. So we can do imaging in the anterior segment, posterior segment, optic nerve head, glaucoma testing as well. So you can see macular edema. This is the center of the macula, it's edematous, and center involved in diabetic macular edema, non-center involved in. So normal contour of the fovea on the center of macula is like this. So any change of the anatomy here would give rise to drastic effect of the vision. So how the optic nerve is formed from the retina. So you have the ganglion cell layer, nerve fiber layers, and which goes into the optic nerve. So these are the OCT images we do for glaucoma. And B scan is an ultrasound scan. We check the involvement. So this is a retinal detachment. Retina is detached. It's the optic nerve. Vitreous hemorrhage. This is the globe, and you can see a bit of lens, vitreous, optic nerve, retina in this image as well. So challenges. So sometimes we have been referred with other specialists, and one thing is hydroxychloroquine. So people are given hydroxychloroquine for various inflammatory arthropathies, arthritis. So there are specific guidelines. Special Royal College of Ophthalmology have guidelines. So generally, annual screening. Generally, if you don't have, if you are on 200 milligram daily dose, and if you don't have renal problems, and if you are not on tamoxifen, ideally speaking, you can see them after 5 years. But generally, if it's more than 200 milligram BD dose, then you have to see them annually. So it is the responsibility of the prescribing physician to refer the patient for the screening. So it should be ideally performed within the 6 months, but definitely within the first year of the treatment. What we do is we do the fundal photography with autofluorescence OCT visual field 10-2, and if needed we have to perform a multifocal ERG. So there are definite, possible and probable toxicity. Definite toxicity, actually speaking, the ophthalmologist, they should not stop the treatment, but then they should refer the patient back to the rheumatologist to suggest an alternative treatment. And if the patient no longer on the hydroxychloroquine or chloroquine, then we need not to continue a screening. And it's because this is a cumulative accumulation of toxic substance, so even if when you stop it, the effect might be still continuing. So it's important, like, you know, you make sure you do the screening and catch them early before it permanently damages the vision. And it's also the patient's responsibility here and abroad, like, you know, to make sure they are eligible for driving or not. So with the ophthalmologist, I think if they are not suitable for driving, especially public vehicle, they should not. And another is the topiramate. Topiramate is given by the neurologist and most of the sometimes general practitioner I've seen for various kind of headaches, seizures, and almost every condition now we are on topiramate. And recently I had a patient who I thought he having a red eye, just conjunctivitis, almost like, you know, was having a kind of a small refractive error as well. And then it looked like conjunctivitis, you know, like history of 1 week of redness, tearing, almost like, you know, I just noticed the antechamber was shallow, but the patient didn't come up with, you know, seeing a headache and neurologist, so I almost missed it. Then again, looking back, the eye, generally we don't, each and every patient we don't check the eye pressures, right, you know. So I almost missed it, but then luckily she was about to go, then I asked her to stop and again check the eye pressure. It was high, so it was a topiramate secondary acute angle closure attack. So generally they have this negative myopic shift because the whole iris, diaphragm, lens, everything shifts a little forward and closes the angle, and they have a bit of a myopia. That's like, you know, they can't see the distance clearly there. And that patient was wearing glasses during school time, so I just was misled, but luckily I didn't miss that patient. And sometimes they can have diplopia, nystagmus, posterior scleritis. More than these two are common. Generally within the 2 weeks of initiation of treatment. And what we should do is you should stop topiramate immediately. Can give atropine or tropicamide. I didn't give any. The eye pressure was 30, so I didn't give any hypertensive agent. I just give tropicamide, which was available because atropine is not freely available now. Because I shouldn't give acetazolamide, but it can worse cerebral edema, so I didn't give any acetazolamide. And then I saw the patient 1 week's time, pressure has come back to normal, and then I referred to the neurologist to start an alternative medication, and then the patient vision was better. And this another drug that we sometimes get referred. There are specific guidelines. You shouldn't start vigabatrin on patient with visual field defects and child over 9 years, because child less than 9 years can do a visual field test, and these children can have perfect 6/6 vision with absolute constricted visual fields. So you might have to do other investigations as well, so we might get caught, you know, in this situation. So we have to be very careful. So these are challenges that we might face in our practice. So other problem, thyroiditis. You know, as an oculoplast surgeon, many referrals that I come across, whether you know what to do, whether you have to give IV methylprednisolone pulses, and you know, and then sometimes, you know, recently I got a referral. The patient is like Down syndrome, mentally not very capable. You know, whether to do the radioactive iodine treatment, because as you know, it can worsen the thyroid eye disease. So sometimes it's like, you know, multidisciplinary management. You have to manage with the endocrinologist, And then sometimes if it is optic neuropathy, sometimes you have to do an orbital decompression. So generally they are cosmetic and they are not done in the acute state. So even in the worst case scenario, sometimes it makes a month or so for an urgent decompression, because thyroid levels are not stable and the patient not fit for surgery, and you can't do orbital surgeries under local anesthesia. So generally it's in the convulsion phase that we do surgery. So from here, like, you can get it down to this, and you have to do the right amount of decompression in this patient. So kind of very challenging, because every patient is different, and you have to talk with your colleagues before embarking on the decision. And lead problems I found, ptosis, every lead is kind of challenging, because it's when you look at a person, it's the contour of the eye, the shape of the eye, which really matters, gives you a kind of a attraction or distraction or whatever. So there are many eye problems that we have to come to, or everything is challenging. So what to offer: surgery, Botox injection, lead crutches, or conservative management. So generally, why it's kind of a patient who has undergone ptosis correction. So you can see these eyes. Ptosis is when the eyelid is in a lower position than what it should be. So we measure marginal reflex distance and levator function, and we measure everything, eye movements. So generally we look into every aspects of the possible causes. So sometimes we might get tricked. So I'll come to ptosis. So ptosis is involutional. Involution with aging, the levator function goes down and it's more stretched, so it becomes ptosis. Then generally, if it affects the visual axis, then probably you have to do the surgery. And neurological, when the nerve is involved, myogenic, the muscle, like myasthenia gravis, mechanical, there's something hanging over here like a lid lump, pulls the lid down. And pseudotosis, it looks ptosis because the eye is small sometimes. So I've done some research, congenital and acquired histological and analysis. So these are more in female. I don't know why. Probably female patients come to the doctors more. I don't know. So majority of left eye ptosis is much more common. So everywhere, like other studies also suggest left eye is more common. We don't know. And refractive error, squints are much common with the severe degree of ptosis. So sometimes these congenital ptosis can be very tricky. So sometimes they might be associated with Oculoplasty. So in this patient, coming with the congenital ptosis, she was very keen on getting the lid elevator, but then you have to look very carefully. So when I lifted the lid, the cornea was like this, and then when I everted the lid, so it had the subtarsal, the lid. There was inflammation, so it was due to inflammation. So you shouldn't jump into surgery and do the surgeries because there might be other things involved, because you might not see it. Once I did a patient with congenital ptosis, so having ptosis, mitosis, stable ptosis throughout the years. Patient of 20 years, and generally you don't do CTs for this patient and exclude the other pathologies. And I did it, but 6 months it was very stable. Then she came with the proptosis and a ptosis. So that child has had a dermoid cyst, which was very small at that time, and it was stable. Dermoid was the one which was pressing the levator muscle and causing ptosis. So you generally don't do CTs for those patients. And then the dermoid had hemorrhage into it. So that was the reason for. So you can get caught in these situations. So other challenges, like sometimes children, this was 1.5 years, there's some lesion behind the optic nerve. So generally 1.5 to 3 years, common cause neuroblastoma, and then nephroblastomas are common, like up to 3 years. Then other orbital tumors, they differ according to the age. So getting the biopsy in this child, like it was perfectly seeing eye, was very difficult. So these are very challenging cases because the anatomy is different. You don't know, like, generally, like while we are driving, we know the dimensions of our vehicles, how far the front, left. So generally in children, sometimes we don't know exactly, how long we have to go in this surgery. So these are very, very difficult. So managed to go through the periosteum, go down, and managed to take the biopsy. So this was Ewing sarcoma. So the management was totally different. So you have to take biopsies in this, and these are very, very challenging cases. And this lady was about to get married, and she had multiple lesions. So in 1 month's time, so they are pressing. Sometimes these patients are very, very challenging, like, she wants everything before 1 month and to be perfect at the wedding. So these small cases. And another case, like, patient came with kind of this post-op patient, not a proptosis, but kind of enough than that, eye gone in. So it was kind of a solid tumor, just came to me. It wasn't a referral as well, and then found a solid tumor. Then I admitted immediately, and it was just asked her. She was 53. Asked her, and then found that, my medical officer found that she has a breast CA. So, and it was a secondary in the orbit. So sometimes, you might just miss these things. Sometimes you might take time, like ask them to come in 3-4 months. Then these things might have progressed. So this was early treated in Colombo as a neurofibroma, but it started growing again. Then it was neuroendocrine tumor. So sometimes you have to do re-biopsy, so you don't sit back on a previous diagnosis. Might be something else. So meningioma, sometimes you have to go with the neurosurgical scene, and the anesthesia, now not having finding anesthetists and finding theatre time is also challenging, because now we have to share one theatre with all the other ophthalmologists, and having a combined surgery is almost impossible. So we have to depend on the neurosurgery and the other surgeries, like, to do the surgery. So it's very challenging in that sense as well. So this patient, another patient, this was while I was in Colombo. The patient came with a solid tumor here. Then I thought it was just the biopsy. Then the ENT surgeon, very esteemed, he was very confident that it was a squamous cell carcinoma. So I saw the CT the day before, and it was just on the medial side. Then when I was doing the surgery, like, he cleared the frontal sinus area, the tumor, and then I found that it's moving towards the lacrimal gland. Then again I saw the image, but then I didn't remove the tumor over here. But luckily I left it, but unfortunately we had to compromise the trochlear nerve which comes through here. And then luckily I didn't remove the lacrimal gland. And the histology, even though it was infiltrating, going through the bones, and it came as non-specific orbital inflammatory disease, where the patient responded well to the steroids. So sometimes you feel like you are very sure with your experience. Sometimes you don't know what it is. Like, it's sometimes very, very challenging. Child with lid retraction, and the surgery came well, very well. And this lady is all multiple traumas, and then after the surgery, but still a bit of work to be done. And entropians, sometimes very challenging, sometimes it's easy, but then sometimes they do resolve after surgery. So ectropion is the same. So sometimes they look very innocent and very easy, but then these things are sometimes challenging, because, like, you have to do multiple times, and so there are some challenges that we have to face as surgeons. We have to collaborate and work with the other people who are also very busy. So ultimately, I think I have managed to update you on common eye condition and some challenges that we face, and the forum is open for questions.
Well, when we were medical students, there was a lot of eye injuries due to lime. And say lime being squeezed into eyes. I guess I remember Dr. Regis insisting on a lot of things. Do you still do those things?
Exactly, yeah. I mean, I think there's a bit of awareness now, but still we get enough Lyme injuries, and as as discussed earlier, so they give grave implications because the Lyme injuries, they penetrate much severely than an acid injuries, and if sometimes we have to prolong, we have to treat them for a very long time, because like sometimes the cornea is gone, sometimes there's blood vessels growing into the cornea, and you have to do and it's very difficult to do a cornea transplant on those patients because the high rate of rejection. Then for us, they come with the lid problems, the lashes turning in all the time and irritating the cornea and giving rise to cornea, and sometimes eyes, they don't close properly because of the cicatrization, the scarring, and it's very grave. Like, but luckily it's not as it's used to be, because I think there's a bit of awareness and people are a little careful now, I think.
This domestic eye injury, so something in the playground or whatever, and they say it's going to take half an hour to 1 hour to come to an eye hospital. If there's no obvious injury, just leaving the eye with running water or ordinary water is good enough.
Good enough. But it's better if at some point, not immediately, but you make sure you come to eye unit and make sure that sometimes these small particles can lodge and give rise to problems later on. And even like if it is blunt trauma, then you might have like traumatic uveitis, that eye might get inflamed a little later. So it's better if there's something, just don't forget it. But then if the smallest complaint that you have, better to come to our unit and show. But as you said, like washing with the running water is quite safe unless they are contact lens wearers. If we,
I heard some somebody said better not wash with water, come like that to the hospital if there's a splashing injury or something.
No, I think like
better not wash with water was there.
As long as it's kind of a, if the patient is contact lens wearer, and if the patient can see, and it's a decision that has to be made at that time. So I would feel like washing with the water is kind of a safe option, unless you can't see, or as I mentioned, the patient can't open the eye and the pain is so much. If it's a white eye, then it's safe to wash, but make sure you come to the hospital. Sometimes it might be something that you don't think it is. It might be something severe. So always safe to come to the hospital and get an assessment done.
Thank you very much for your interesting lecture. I think you have already touched on this one as well. The wearing of spectacles is among school children actually. During our school days, we rarely see a colleague wearing spectacles. Nowadays, if you take a class, probably sometimes the majority of students are wearing spectacles. Is it only the use of electronic devices, you think, or any other contributing factors, or is it the detection rate has increased with the facilities available? What is your opinion actually?
So in my opinion, like now it's mainly the myopics since you can't see the distance. So it was more common in like the Singapore, Southeast Asian community, because like they were used to like high-rise buildings, so they can't go out, and like so they were used to near work frequently, like a couple of decades earlier. So it was more prevalent on those populations, And after the advent of COVID, and and even before that, now people are more used to playing games and all, like it's not our days like the generations after. And it's much more common with the people who always use the near vision rather than going out and playing in the field. So they are much more common and it's much more prevalent in current populations. And the detection, as you mentioned, the detection rate is much higher because there are more screening camps in school. That also contributes, not only like they are just being they are without detection, now they are detected much more as well. So both factors, definitely the devices use has contributed to the myopic. It's kind of they call it as an um, like almost everybody is getting it, almost like, as you said mentioned, it's very common now. I'm sorry, like I had to rush through certain ones because diabetes, certain refracting, or itself it can be a lecture of 1 hour, so I had to manage the time, so I had to rush through.
So in the absence of any questions, let us thank Dr. Kavinda Masinghe and let us show our appreciation.